Chapter 18, Multicultural Diagnosis and Conceptualization. So in order to be an ethical practitioner, you have a duty to commit yourself to gaining knowledge, personal awareness, sensitivity, and skills that are pertinent when working with diverse client populations. So we've talked about this before. These are just foundational skills, right? The ability to do research when you don't know something about your client, the ability to listen to your client and pick up on their language, that kind of stuff. The ability to check your own biases and be aware of what you're dealing with, any countertransference, right? Those kinds of things. So all foundational skills, and they're of particular importance when it comes to culturally sensitive counseling because every single counseling session you have will be culturally sensitive, right? We all have different backgrounds, different experiences, different profile plots, like I've talked about throughout each chapter. So in particular, when working with culturally diverse client groups, which, like I said, all groups are, you want to be able to do an overall cultural assessment. So the definition from your textbook is that this means that you have an understanding of the cultural framework of the client's identity, cultural explanations of the illness they're experiencing and any help-seeking behaviors, cultural meanings of adaptive functioning in social context, and then cultural elements in the counselor-client relationship. So in particular, the multicultural and social justice counseling competencies can be really helpful. So these are guides that have been created for counselors towards multicultural and social justice competence within the areas of counselor self-awareness, client worldview, counseling relationship, and counseling and advocacy intervention. So I've talked about how there are multiple guidelines out there that have had a lot of research that have gone into them and can be very helpful. So this would be the multicultural and social justice counseling competencies guidelines. So you can look those up and refer back to them. So multiculturally competent and socially competent counselors should work to develop these competencies and abilities for the cultures of clients whom they predominantly serve. So keeping that in mind with your client base. Develop a referral base of counselors for clients from cultures with which they are less familiar with. So I've talked about this in before. Having resources, maybe a resource binder, that kind of thing, connections to help your clients. They should avoid jumping to conclusion about clients on the basis of cultural groups. I've talked about this over and over again. So we have all of this great information. We have all of these statistics, all of these trends, but that doesn't mean that we can generalize. This is more of information to have in the back of your head to look for red flags and to maybe understand your client a little bit better, but not make any assumptions. A culturally competent counselor should also acquire knowledge about different cultures, norms, and interactions. So that's also going into that research component. So always being open, looking for new information, having more awareness, right? And then a counselor should be committed to building ongoing self-awareness of values and biases. So always looking in on ourselves, any countertransference we may have with our clients, that kind of thing. Culturally sensitive diagnosis and conceptualization can be challenging, and this is especially so when you're diagnosing clients whose cultures may differ from the dominant culture or your own culture worldview, which typically is the same here, right? So most of us have that American culture that we're viewing our client through, and if that's different than the client's culture, then it may be a little difficult to diagnose. And this kind of gets into that idea of what is normal and what is abnormal as well, because something that could be seen as completely abnormal in the American culture, which is what most of us are used to, could be viewed as completely normal in a different culture. So keeping that in mind, are your clients' issues and symptoms significantly impacting and affecting their day-to-day life in multiple contexts? So at home, at work, at school, that kind of thing. Is it actually an issue, or is this something that is a normal part of their culture and it's causing no problems at all, right? So looking at all of that stuff and keeping that in mind. The usefulness of the DSM has been challenging for people who differ from the dominant culture. So the DSM's development was grounded in the knowledge of European Americans and on evidence from research studies that did not include diverse participants. So we talked about this a little bit before with assessment and norms, norming populations. So DSM, same thing. Most of the norms there are European descendants and not so much diverse clients. So that's something to keep in mind. And another thing to think about is that no diagnosis contains the whole or absolute truth about the problem issues. Cultural validity in assessment. So ignoring the importance of cultural differences when diagnosing and assessing individuals from different diverse backgrounds can actually lead to unfair and unethical testing practices and diagnoses. So, for example, the wording, illustrations, layout, and contextual information that's embedded in diagnostic questioning reflects the language, ways of thinking, and experiences of a particular cultural group. So, in this situation, we're talking about that European cultural group, that American-based cultural group, right? So it's going to be reflected in our assessment and in diagnosing. So it's likely that some diagnoses and test items might privilege individuals from one cultural group, so here, that main cultural group, right, and penalize individuals that come from other cultural groups. So the DSM-5 has significantly affected the way counselors diagnose mental disorders by moving away from the categorical axial system and into a dimensional system. So with the old binary categorical classification system, symptoms were either present or absent and defined as normal or abnormal. There was an over-reliance on the other or unspecified categories of diagnoses, and many disorders have high co-occurring symptoms, we know that, right? And also have high comorbidity, multiple diagnoses taking place at the same time, and thus diagnostic subtype specifiers and severity ratings have been added to the DSM-5, so in 2013, right, to make it more continuous. So this is trying to fix those issues that we were seeing before, fix the vagueness, right? So the DSM-5 contains more than 67 emerging measures that will require score validation, including cross-cultural score validation. An emerging measure included in the DSM-5 is the Cultural Formulation Interview, CFI, which can help clinicians understand the client's perception of the problem issue from his or her cultural context, perceptions of etiology, context for the problem issue, perceived support, cultural factors affecting self-coping and past and present help-seeking behaviors. And then another thing to keep in mind is that cultural validity and assessment requires that mental health professionals take into account specific cultural backgrounds and norms, whether through this CFI or not. So most people don't use this CFI, Cultural Formulation Interview. Really, the DSM-5 as a whole is still pretty new, so a lot of it, I still see people going off the 5 axes, that kind of stuff. So it takes a while for new things to get some traction. So if you find this interesting, you might want to go ahead and start using it. And I'm going to pull it up on the DSM now. All right, so here is the DSM. And we can see here Section 3, Emerging Measures and Models. So Section 3. And you can see that we have cultural formulation, the cultural formulation interview, right? So I'm going to go to that section. Okay, my numbering's a little off since this is a PDF. So here's the cultural formulation section. So you can scroll down. This is all really good information too. But here's the interview. So 16 questions is a semi-structured interview. So it's going to give you some prompts, kind of like a script, right? So here's an example here. Your introduction for the individual. So I would like you to understand the problems. I would like to understand the problems that bring you here so that I can help you more effectively. I want to know about your experience and ideas. I will ask some questions about what is going on and how you are dealing with it. Please remember there are no right or wrong answers. So if you're familiar at all with assessment, like any of the Wechsler system, that kind of thing, the Wyatt, the WIS, the WACE, all of that. So you have these prompts and you read them like a script to your client. So same thing here. And then there are also additional prompts and queries. So what brings you here today would be a question, and then here there's instructions. So if the individual gives you details, few details, or only mentions symptoms or medical diagnosis, you can probe further. So people often understand their problems in their own way, which may be similar to or different from how doctors describe the problem. How would you describe your problem? So that's like an additional query there that you can give. So we see there's different sections and all the way down. So 16 questions, right? And there's different sections. So client-patient relationship, barriers, past help seeking, and it reminds you of the instructions here. So instructions to the interviewer are italicized, right? So you can use that if you're interested. I think it'd be interesting and maybe fun to practice it with other classmates and see how it feels if you want to incorporate that into your work. Other information in the DSM that's pretty fruitful here would be the cultural concepts of distress, so like those culture-bound syndromes, right? So this is all good information. I would suggest reading through it. Okay, so normal versus abnormal. We've kind of touched on this already, but we're going to talk about it a bit more. So fundamental to any diagnostic process are questions about where the line should be drawn between normal and abnormal. Where does that line lay? So people in power make these decisions, and agreements about those decisions tend to change over time. And it depends on who's in power and the spirit of the times, right? What's going on. Economics also encroaches on what is normal and what is treatable, since increasing the number of reimbursable diagnoses increases the treatment domain and profits of mental health providers. So these normal, quote unquote, problems in living, so like worrying, feeling blue, having obsessive thoughts, not sleeping well, feeling lonely, that kind of thing, may be moved into the realm of diagnosable mental illness or pathology. And that's so that for insurance purposes, right? So any client that you see, if you're billing insurance, they have to have a diagnosis in order to bill. So there's going to be something. And some people might put something fluffy like adjustment disorder not otherwise specified, that kind of thing. So that would kind of get into these problems in living, like a loophole to do that, to see your client and have their services covered by insurance. But it's all about money when it comes to diagnosing, really, if you get down to it. Yes, there's a huge aspect of diagnosing, especially in a perfect world, is this idea of a shared language so that you can talk with other providers and read notes and read referrals and this kind of thing, and everyone's kind of on the same page because it's a shared language, like I said. But on top of that, what it really comes down to most of the time is being reimbursed. I mean, you have to get paid, you have to put food on your table, and you have to get paid for your work. So you're going to reimburse with insurance, and that means it's going to be coded and there's going to be a diagnosis on the chart, and that's kind of what it comes down to at the end of the day when it comes to diagnosing. So something to keep in mind, and especially when diagnosing clients who maybe have different cultural backgrounds than yourself, and you may have misdiagnosing and overdiagnosing, which we tend to see a lot when someone is diagnosing someone who's very different than themselves. There tends to be misdiagnosis and overdiagnosing. So keeping that in mind with your clients, not wanting to add to, I've had people refer to it as like an Easter egg basket, right? And you just keep adding all these Easter eggs and eventually they're kind of overflowing. So you don't want to be someone who's adding yet another Easter egg to their basket, because once you've put a label on someone, they carry it with them, right? It doesn't just disappear. It doesn't go away. And sometimes the client will take it on as part of their identity, which can be an even bigger issue. So all that to say, you want to be careful when it comes to diagnosing, because you don't want to overdiagnose and cause more issues than you have to, right? So the recently added diagnosis of disruptive mood dysregulation disorder, that's one example of this, was argued to merely demonstrate typical childhood behavior. So they added this diagnosis to the DSM in the 5th edition, 2013, because too many children were being diagnosed with bipolar disorder too young, which was inappropriate. So they added this new disorder, but what the textbook is saying here is that a lot of people argue that this shouldn't even be a disorder because these are just normal childhood behavior. So it's pathologizing something that shouldn't be. This affected children more so that were living in poverty and had difficulties with social support. So that, I'm sure you can imagine, just made things even worse, because now, this disorder is seen as kind of like it's very negative, right? It's a boogeyman type diagnosis. And if you're giving it to a child who's already struggling and is in poverty and doesn't have social support, then you're just making things worse for them, right? You're giving them a very negative label. So if a client's context is not accurately considered, symptomology may result in something like a DMDD, disruptive mood dysregulation disorder, misdiagnosis, when the behavior may actually be the result of normative adaptation to a child's environment. So what they have to do in order to survive, or what they perceive that they need to do in order to survive. Grief reactions may, depending on cultural context, closely resemble depression. So another thing to keep in mind. In the DSM-5, if a person now meets the criteria for major depression, he or she should be diagnosed with major depression even if he or she is grieving. So even if it's part of their grief process, within the DSM-5, you give them that diagnosis of MDD regardless of reasoning, even if it may be short-lived, because it is part of grief, right? So this has led to an increased pathologizing or psychologization, locating problems at the level of the individual rather than looking at their environment and the context, that kind of thing. The responsibility for problems and for change becomes solely the individual's, despite the availability of alternative, more systematic explanations and potential remediation of problems. So like sexism, racism, poverty, that kind of thing. When individuals come from a culture that is more collectivist, deferential, or passive than the mainstream America, their presentation may meet the diagnostic criteria of dependent personality disorder as well. So something else to keep in mind. So category fallacy is the application of diagnostic categories to cultural groups for which they were not developed and have never been validated. All right, so I wanted to pull up the DSM real quick to talk about those examples that we just discussed. So here's disruptive mood dysregulation disorder. So severe recurrent temper outbursts that can be manifested both verbally or physically. These are inconsistent with developmental level. They occur very often. The mood in between these outbursts is persistently irritable or angry most of the day. So that's the gist of the symptoms there, right, for the criteria for diagnosis. And if you look at that, I mean, like I stated earlier, you can see that depending on what's going on in a child's environment, this may be a part of survival. It may be something that they need to do, right? So having these outbursts may be because things aren't going very well at home. Being irritable and angry, maybe just, once again, there might be abuse occurring. They may be in a lower income area and they may not be getting good sleep because they don't feel safe. So taking into account all of these things so you're not adding yet another label that may be more damaging to your client, or may have others view your client in a different light and then cause even more damage, right? So keeping these things in mind. And sometimes DMDD is the proper diagnosis to give, but a lot of times not so much, and I have seen it overused quite a bit. Okay. When it comes to depression and grief, I tend to prefer to give this diagnosis, so persistent complex bereavement disorder, if I have a client who is experiencing just that persistent bereavement, right? So maybe they would meet criteria for major depressive disorder, but that's pretty heavy diagnosis. So this is giving a more specified diagnosis that's less vague, that shows other practitioners a better picture of what's going on, because that's what diagnosing should be, right? A picture of what's going on with your client, so that they can read that and have a general understanding of what to look for, and what to talk with the client about, and the potential prognosis and treatment planning and that kind of thing. So this would be a better diagnosis for a client who's experiencing complex bereavement, right? Complex bereavement, complex grief. Okay, so overdiagnosis, underdiagnosis, and misdiagnosis. So overall, any behavior that doesn't match this, like we talked about, American subgroup, right, is sometimes labeled as pathological. So gay men, lesbians, transgenders, racial and ethnic minorities, women, and non-traditional men may be overdiagnosed with certain disorders or misdiagnosed entirely. So we see the research shows that African Americans have been overdiagnosed with psychosis and underdiagnosed with depression. African Americans are more likely than whites to be diagnosed with schizophrenia, substance use disorder, and dementia. Latinos have been diagnosed with schizophrenia at 1.5 times the rate of whites. And just anecdotally, I have seen that persons of color have been overdiagnosed with a diagnosis such as schizophrenia, while I'll see a white client with the same symptoms being diagnosed with bipolar disorder. So there's kind of this gut response feeling that maybe schizophrenia is a little more intense than bipolar disorder. So maybe that's part of what's going on there, but I see this, I especially see it in emergency rooms. So when I have clients in hospitals, and I've seen the intake paperwork, that kind of thing, and they've come through the emergency department, anecdotally, I have seen that. So yes. We also see that women are disproportionately diagnosed with certain personality disorders. So I'm sure everyone knows what they're referencing there. That would be borderline personality disorder. We also see that antisocial personality disorder is disproportionately diagnosed in those with lower socioeconomic statuses. So evidence indicates that misdiagnosis occurs as a result of stereotyping and overlooking the perspectives of the client. So like the environment, that kind of thing, right? Another thing to keep in mind when it comes to diagnosing the DSM is sampling bias. So research has ignored many who are in need of counselor services, so those of lower socioeconomic statuses, women, minorities, and the unemployed. And sampling has included a disproportionate representation of the sexes and minority populations. So something else to kind of keep in mind. Culture often influences what symptoms are allowed as expression of suffering. So we've talked about that quite a bit, those symptom pools, right? So what symptoms are deemed acceptable within the culture that your client is in? How are they going to display their pathology? How individuals are allowed or encouraged to cope with distress is also influenced by their culture. Culture influences how those around the individual respond to distress or problematic behavior. So at what point is intervention deemed necessary? That kind of thing. When are they going to seek help? What are considered acceptable help-seeking responses and interventions, and who may intervene is also going to be influenced by culture. Culture also influences the counselor's perceptions of a disorder, their style of interviewing. So what questions are they going to ask? What questions are they going to give more queries about? What are they going to hone in on? What are they going to remember after they leave the intake? What are they going to write down? All of this stuff, which I think we've touched on before. It's also going to affect the counselor's theoretical perspective. I know I've talked about that. The classification system that they choose to use, and their purpose for making a diagnosis. So as much as we want to say that all of this stuff is standardized, right? it's still pretty objective when it comes down to it. So something to really keep in mind when you give a diagnosis. Would your colleague give the same diagnosis? Could you, this should always be your question, could you argue your reasoning for your diagnosis in a court of law? Do you have plenty of evidence there? You really want to spell it out why you give a diagnosis and be able to explain it and argue it in at any angle, right? Thus, culture is inextricably linked with both normal and abnormal behavior. So assessing development, experience, the expression of a behavior, and the understanding of the ways in which diagnosed people are perceived and treated that seems imperative. Effective diagnoses require consciousness of cultural norms, values, and typical behaviors. So feminist theorists believe that women's anger, depression, and discontent have been reframed as medical or psychiatric symptoms. As a result, the often difficult and distressing life circumstances of women have been disregarded. The roots of women's so-called psychological problems have many times been social and political rather than individual and intrapsychic in origin. So something else to keep in mind. When examining the prevalence of specific diagnoses rather than overall rates of mental illness, there seems to be trends in gender and diagnosis. So, for instance, we see that men's prevalence rates are higher for substance use and gambling disorders. And something else to kind of keep in mind here, too, is those symptom pools that I've talked about. Women's prevalence rates are higher for anxiety disorders. Prevalence for bipolar 1 is equal in men and women. But women have been found to experience more rapid cycling, depressive episodes, and major depression than men. Most personality disorders occur more frequently in men than women, except borderline personality disorder, histrionic personality disorder, and dependent personality disorder. Obsessive compulsive personality disorder is observed twice as often in men than women. And then avoidant personality disorder is equally prevalent between the sexes. Gender prevalence studies indicate few gender differences in diagnosis of neurodevelopmental disorders before school age. So I've talked about that before, I'm pretty sure. We tend to see big changes occurring between boys and girls at school age when puberty starts to hit, right? We tend to see that they go from being pretty equal with diagnoses and symptoms to seeing a split. So once children begin school, boys are more frequently diagnosed in middle childhood years, and while girls are more frequently diagnosed in adolescence and beyond. So we see girls having issues occurring a little bit later than boys. Girls' problems are more likely to be overlooked, underdiagnosed, and untreated. And this is due to a lack of ability to observe young girls' distress when it is present, and a traditional notion that it is less important for girls to succeed academically. Also, boys tend to have more externalized and behavioral type problems, so they stand out a little bit more, and this can also result in more over-pathologizing. Children are in general often overdiagnosed or misdiagnosed, so children under the age of 13 are often overdiagnosed with ADHD, and I've 100% seen that anecdotally. Adolescents are often overdiagnosed with conduct disorders and substance use disorders as well. Additional concerns about the assessment and diagnosis process emerge when considering older adult clients too, so that's something to keep in mind. Counselors may struggle with differentiating between normal aging concerns from symptoms of depression or major and mild neurocognitive disorders. So disinterest and forgetfulness, that could be viewed as a normal part of aging. It could be viewed as a part of dementia. It could be viewed as the client is experiencing depression. So they're, kind of not all with it because they're very down and sad and maybe having a major depressive episode. And so their memory is being affected, right? So viewing it from all the different perspectives. Psychological symptoms may also be caused by a physical disorder or medications aimed at treating a medical problem. So, same thing with memory, could be due to their medication. So, being an advocate for your client, looking at their medication list, looking at symptoms that may be associated with it, and helping them to understand that so that they can ask their provider about their medical issue or the prescription that they're given. Because I've seen that a lot in hospitals. So research is not simply knowing a client's sex in order to influence the diagnostic process, even among experienced practitioners. So, for instance, female and male clients may receive different diagnoses even when they present with identical symptomology, which is just crazy to think about. So women from traditionally marginalized groups may also find themselves pathologized to an even greater extent. So we see the battle over the DSM's inclusion of premenstrual dysphoric disorder has drawn attention to political and gender struggles inherent in the development of the DSM. So 8% of women report experiencing distress that impairs daily functioning. So this is in contrast to most women's mild PMS symptoms. So this is 8%. It's clinically and significantly impacting their day-to-day life in multiple contexts, right? So PMDD has been linked to polymorphism of estrogen alpha receptor gene ESR1. So that's something to keep in mind. It might be more of a medical issue. Correlations have been found between PMDD and history of sexual abuse, domestic violence, sexual discrimination, depression, and anxiety. And then dysphoria related to the menstrual cycle may result from culturally determined negative associations with menstruation or from physiological or hormonal changes. So there are all kinds of things to keep in mind when you're diagnosing, and this is a perfect example of that. Research and theory on mental health implications of socialization have further clarified some ways that gender-specific socialization harms people or even causes them distress. So research suggests that girls silence themselves in their desires, abilities, and interests, so like they give up their voice, that kind of thing, as they move into adolescence, because they believe that such silence is necessary to succeed in intimate relationships. So the research shows that the higher the voice rating of the child is related to higher ratings on masculinity, and the lower the voice rating is related to lower ratings on masculinity and higher ratings on femininity. So women in North America are twice as likely as men to experience depression in their lives. This may be related. Gender differences seem to begin during adolescence, just when girls' socialization becomes different from boys' socialization. So often boys are taught that men should be active, masterful, and autonomous, whereas girls are taught that women are to be passive, compliant, and committed to interpersonal relationships. So we see kind of these different roles that are pushed on children around adolescence and around the time that they're hitting puberty and that kind of thing, and that's going to affect their mental health differently. Findings show poor health and relationship difficulties result from a lack of balance between individualism, which would be maleness, and relatedness, which would be femaleness. Being male or female turned out to be less relevant than the person's degree of masculinity and femininity. Higher femininity scores and lower masculinity scores are correlated with higher depression in both sexes. And higher levels of masculinity results in lower levels of depression in both men and women. So what that's saying is it's not so much about gender, it's more about gender expression, so masculinity or femininity, that kind of thing. And part of counselors' focus ought to be on changing the biases in society that damage both men and women. Environmental factors that may account for the high rates of depression and other disorders in women may include greater restrictiveness of women's roles, so being defined in terms of others' needs, that kind of thing. An inability to measure up to standards of women who are held up as examples of those who have, quote unquote, made it. A lack of social networks and supports, marriage, separation, and divorce, single motherhood and its attendant stress, more frequent experiences of gender based discrimination, higher prevalence of living in poverty with its attendant stressors, inequities related to marriage, family, relationships, reproduction, child rearing, divorce, aging, education, and work, work outside the home that is low status or low pay, and women's roles being defined in terms of the needs of others, which serves to relegate women's own needs to secondary status where they remain unmet. Okay. Counselors should always remain aware that the DSM diagnosis is only one piece of a comprehensive assessment. So you never want to go with one data point, right? You want to have lots of pieces to make a nice big puzzle, paint a good picture. Potential benefits of diagnosis include having a framework for describing complex phenomena, increasing one's understanding of symptoms, and promoting self-awareness and self-acceptance within the client. Diagnosis contributes to a common language that facilitates communication among all the individuals involved in the client's treatment. Comprehensive diagnosis should integrate the perspectives of the client, the counselor, and significant others, such as friends and family members. So you really want to get data from multiple perspectives, right? The counselor might include the client's developmental history, other problem areas, family relationships, medical and treatment history, and client strengths. And the counselor is not an expert doing diagnosis to the client, but a facilitator in forming diagnostic meetings with the client. So if you view it from that perspective, it may help a bit. Some suggest that there are universal diagnostic categories and descriptors that apply regardless of situational and cultural factors. Others claim that it's impossible to extract an individual's lifestyle from the culture that shapes it. Large-scale epidemiological studies that may support universal diagnostic categories have often suppressed the quote-unquote voices of small groups. However, separating culture-bound syndromes in the DSM and giving them special restricted status makes them vulnerable to being dismissed or discounted. I rarely ever hear of colleagues using these symptoms from the back of the book, right? It's like a last thought sometimes, but they rarely get used. They get discounted and dismissed, right? The culture and diagnosis group believes that a culturally sensitive DSM would include more extensive guidelines for using the DSM in culturally sensitive manner, a cultural axis, a cultural issues section under each disease, condition, or chapter, examples of culturally normative client experiences, culture-bound syndromes, and an appendix related to acceptable problems in working with interpreters. To provide culturally sensitive assessments, counselors should begin by exploring cultural systems and structures, so like community structures, families, schools, interaction styles, concepts of illnesses, life stage development, coping patterns, and immigration history. Also cultural values, so time, activity, relational orientation, person, nature, orientation, and basic nature of people. And then gender socialization and the effect of trauma. An accurate assessment of emotion or behavior is not possible without an assessment of cultural schemas. So the counselor should know what types of emotions a particular cultural group experiences, what emotions are elicited by what situations, what particular emotions mean to indigenous observers, what means of expression of particular emotions exist in that culture, what emotions are considered proper or improper for a person of a particular social status, and how unexpressed emotions are handled. Practitioners are also urged to treat both the illness, so the client's subjective experience of being sick, and the disease, which would be the practitioner's diagnosis. Before diagnosing a client, culturally sensitive counselors should ask themselves, have I been able to separate what is important to me and what is important to this particular client? What do I know and not know about the client's cultural heritage? What is the client's relationship with his or her culture from his or her perspective? How acculturated is the client? What are my stereotypes, beliefs, and biases about this culture? What culturally appropriate strategies or techniques should be incorporated in the assessment process? And what is my philosophy of how pathology is operationalized in individuals from this cultural group? So the feminist analysis opposes traditional approaches to diagnosis and treatment that over-focus on idiosyncratic life experiences, biology, or personality traits as causes of problems. So feminists begin from the position that the personal cannot be separated from the political or social, and they view therapy as a political process aimed at solving social problems. To develop an inclusive feminist identity, counselors can question their own assumptions about what is normal with respect to gender, attend to factors that may influence the expression of gender, and question the meaning to both the client and the counselor of gendered behaviors. Counselors also need to be aware of issues, patterns, or behaviors that occur with high frequency in one gender or the other, the cultural reasons for men and women's positions in a society, and the impact on men's and women's expressions of distress or types of problems. Including the context, so for example, rape, incest, abuse, battering, in the diagnostic discussion creates a very different diagnostic picture than considering symptoms without the context. So like PTSD versus major depression, that kind of thing. Mental health providers are now tasked with why a disorder exists instead of merely categorizing what the specific abnormality is. Conceptualizing symptoms as adaptations or coping strategies may also result in a different counselor-client relationship than what emerges within the medical model relationship. So the counselor might acknowledge the value of the symptom coping strategy rather than viewing the client's way of handling life as inadequate or deficient. And that is it for chapter 18.